This is session 5A. It takes a community building a clinic to serve the vulnerable. We have several speakers. One is Louann Biddick, and the second is Mary Kay Priest. Both are faculty in the School of Nursing here at Marian University. In addition, they're nurse practitioners over at Agnesian. So they're going to lead the discussion today. And they're going to introduce the other members of their group. Everyone should have a green evaluation form. If you complete that at the end, you can leave it on the table or give it to people at the end as you exit the group. But otherwise, you can pick them up at the end.
I'm Louann, and this is Mary Kay.
Hello.
Just so you know us from each other, a lot of people say we're attached at the hip, but that's really not true. I would like to thank you for the opportunity to come and tell you about something that's very dear to my heart. The work that Agnesian has done is very noteworthy, and it's helped the community, not just one or two people, but an entire community. And if we can keep that in the forefront of what we talk about, it's going to mean a lot. I want to tell you first about a couple that really shows me what the Samaritan Clinic is all about. Just kind of put this picture in your mind. The male is 58 years old, lost his job about 3 years ago, no longer qualifies for unemployment. The wife is 65 years old. She's never worked in her life, so she does not qualify for Medicare benefits. They have a very small amount of savings that over the last several months have used totally up. They are now totally dependent on the community for assistance. He suffers from chronic back pain, he has diabetes, he has hypertension, he's recently been diagnosed with peripheral vascular disease. She is a semi-invalid. He uses a wheelchair to get her around. She can only walk short distances. She's overweight, she has diabetes. She recently has developed some significant cellulitis with edema in her legs, swelling that's weeping. She wears Una boots, which is a dressing to control the swelling and infection. She also has some significant hypertension and doesn't want to even take her water pills to help her blood pressure because she would have to go to the bathroom, and that's an effort for him. So here we have a couple with no finances, multiple significant health problems, and what do we do with them? What we're going to talk about today is building a clinic that has helped this vulnerable population. When we think about the vulnerable population, we look first at access, which means how do they get to health care? Where do they go? What do these people do? They are a big group of people. Because of the unemployment rate, we've seen rates of near 10% in this community alone. These people are without insurance and there are no jobs for them. They've been looking, they can't find anything, they've been laid off, they've lost all their benefits, their families are often in the same situation, and they are a group that suffers because of poverty and lack of access and inadequate health care. The providers in the community are all sharing their needs and trying to help them the best they can. But what's happened is they can't always get the access or the care when they need to, and they don't understand how the system works. There's some significant health problems going on. Many disparities exist in this group of Americans because they can't access insurance because they don't have the money to pay for it, and they can't access health care because they don't have the insurance or they can't qualify for it. Did you know that healthcare in the United States consistently ranks behind multiple developed countries? The national poverty rate soared to 12.3%, or about 36.5 million people in 2006, and the uninsured Americans climbed to 15.8% in 2007. It's estimated that these numbers have continued to climb. We all know that there are cutbacks in our state and states across the nation, and what we're seeing are people moving to this community with hopes to get jobs at some of the local manufacturing companies that they hear are hiring, For instance, they may hear that Quad Graphics is hiring or Merck Marine, so they come here because they have some connection to Fond du Lac hoping to get employment, but they don't always do, or it takes some time to be established to get care and get health care insurance. In America, vulnerabilities such as poverty, poor access to care, violence, inadequate education all contribute to this health care disparity, and that was noted in the Robert Wood Johnson Foundation study in 2011.
So I'm Mary Kate, the second part of the Mary Lou duet that we comprise. I do a lot of writing because I like to. Truly, students, one day you will like to write, I promise you. But one of my major works that I'm doing right now is I'm working on a big capstone proposal, which some of you are familiar with capstone proposals and presentations. And what we've chosen to do is to try to quantify what we're doing in our clinic. And we've taken on vulnerability at the Samaritan Clinic as well as at the community care clinic at Agnesian. So you probably all know someone who's vulnerable. Maybe you're vulnerable, maybe it's your parents, maybe it's an uncle, maybe it's an aunt. So visualize that person that you think is vulnerable or that you know is vulnerable, and think about some of the struggles that they go through to get care, to access care, and just to put food on the table. In this great country of ours, it's pretty amazing to think that we rank consistently about 37th in the world for our health outcomes. It completely amazes me every time I go to the CDC, and I'm hopeful that it's going to change. And I'm hopeful today with clinics like this that it is going to change, that our national average and all of our chronic disease issues are going to change, which is one of the big things we're going to talk to you about. So what I found in some of my research is that Americans aren't health literate. And when you go to your provider's office, do you feel like you know what they just said to you? Do you have a pretty good handle on it? I hope that this group of folks that are primarily nursing students and health professionals understand. But in general, Americans don't. About a third of Americans, when they walk out of a provider's clinic, don't know what just happened. They have no idea what the treatment plan is, where to get their medicines, if they're even going to get their medicines. In one research study I read, about 80% of prescriptions that are truly prescribed, sent to the pharmacy in one way, shape, or form, go unfilled. So the patient doesn't even go and get it. How can we treat disease when we can't get our medicines, when we have no mechanism to get our medicines? Another reason is poor understanding of care, coupled with extremely high use of emergency services. This is one of the arms of our studies that we'll be doing, is trying to reduce hospitalizations and emergency room uses. And in this particular city, an organization, healthcare organization, we've had several new clinics pop up. You've probably seen the Next Door Health Clinic or the Community Care Clinic. Those are all efforts to improve access for patients so that they don't feel like they have to use the emergency room. Patients don't use their medications as prescribed, as Louann was talking about with her couple. We see that frequently. If you order a prescription plan, it's important to reinforce it, to have the callback mechanisms to reach your patients, as well as the case management skills to get to your patients. And then lower participations, patients that feel like they're part of the team, and that's part of what we're trying to do, and we'll have our folks tell you they feel like they're part of the team. With the healthcare decision making, and to really make it patient-focused as opposed to provider-driven. And these are some attributes that we're trying to incorporate into our clinic, that every time every patient comes to our clinic, they feel like they're at the center of the care, they're the leader of the team, that they're satisfied with their care, and if they're not, what else can we do differently? That we're also not-for-profit status, outcome-focused, and a climate of safety and concern for the patient and their outcomes. So, a year and a half ago, we did Project the Emergency Department, or Where Do We Go for Care? A group of interdisciplinary individuals, the Chief of Emergency Medicine, Louann, myself, and anybody else who I could twist their arm into participating. Some of you are in the room right now. We try to inform our patients regarding where to go for care. Individuals who were at a lower level of care, they could have gone to different places for care. We try to educate them for future reference where else they could possibly go. You're asking yourself, why do we care? It costs about 5 to 6 times as much to go to the emergency department versus using Easy Care or the community care clinic, etc. And then that patient is left with that large bill. Surely if they are having chest pain or a medical emergency, they need to go to the emergency department. but not all medical issues need to go to the emergency department. This was our goal. It was a very lofty goal. I don't know what I was thinking. And we didn't get there. But like all of you budding researchers in the room know that even if you didn't get there, you can learn some things along the way. And this is what we found. We need to do more. We need to go back to the basics. We need to figure out where in the system we're failing the patient and try to educate them more, as well as create this clinic. And, did you bring the brochures? We have a very nice brochure, and we'd like to share it with you at a future time.
Actually, I'll get some, and they'll be sitting outside of here before we're done today.
But to tell you about the brochure, it lists all the different clinics in the Agnesian system, their hours, as well as what types of patients or what type of diagnoses would be appropriate for that area. And it tries, as well as the phone numbers and the addresses, to try and clear up what's happening so that the patient isn't confused. And frequently I have people, and I don't know if you have this too, if you're out and about and someone says, what's open still? So there's still quite a large amount of uncertainty where to go in the clinic after hours. And this was the process. We began to inform patients at discharge after they've received their care, where else, and for future needs, where else they could go. The brochure still lives in the emergency department. And what we found again is that we needed to do more, and we needed to tackle on chronic disease.
When we look back at some more statistics, about half of all Americans are affected by a chronic condition, resulting in more than $1 trillion in annual costs, and that's a lot of money. When Agnesians stepped back, they realized that it takes a community, and their efforts have been very fruitful in the years. It all started back when someone had the vision to start what they call the Samaritan Place. Began in December of 1992. And it was through the efforts of not only Agnesian HealthCare, the Salvation Army, ADVOCAP, and the Fond du Lac County Department of Social Services was involved. And I know back in the 90s I would volunteer there, and it was located initially, for those of you that are from Fond du Lac, at the Salvation Army, in about 2 rooms that they shared with toddlers and preschoolers. During the day they had some daycare there, and then at night we'd convert the little tables and things into exam rooms. Much of the care was donated time and medications from pharmaceutical companies. We also had social work there who would develop what needs they have and what access to financial programs were available to them. The location and the clinic have changed, and they've changed through the years to different places. They now exist within Agnesian HealthCare, and I'm happy to say that in the audience today are 2 of the people that are very instrumental in the program, a social worker and also a person that manages the cases.
Raise your hands, please. Thank you very much for all your help.
Right from the beginning, the mission was to help the people that are underserved, the uninsured and the underinsured. The mission has remained the same, to provide the basic health services to Fond du Lac County residents who are uninsured. Who do we help? Well, it provides care to those that don't have insurance. It's individuals who live within our county, Fond du Lac County, and have an income of 165% of federal poverty. This doesn't mean that if somebody comes in for a one-time visit, for instance, even some Marian students have used it that don't have insurance, and they live, their residency is in another county. They're not turned away. The assets of less than $5,000 are what's required for a single individual and $10,000 for a couple. For some of us, that doesn't seem hardly enough to live on. These individuals come because they have a need. The income of $1,497 or less monthly, for a couple $2,023 or less monthly. They need to be between 19 and 64 years of age. There are special programs out there that help children, and there are also the Medicare programs that help individuals over 65. Even the case I told you about, the woman never worked in her life, so she doesn't qualify for Medicare. so they fall even more between the cracks. The type of individual and their need is varied. At one time I was saying we get at least one diabetic a week that's blood sugars are between 500 and 1,000, and they either are not treated or haven't been taking their insulin. And that's scary. These people could die if their blood sugars get any worse. The other individuals can be someone with significant pain. They can be someone who moves to the area or is visiting in the area or trying to find work. They're varied, and they have all different diagnoses. The uninsured is becoming a challenge as well. The underinsured, excuse me. The Samaritan Clinic primarily offers non-emergency health care. We're seeing things that we initially didn't see in the program, people with significant abdominal pain that may have gone to the emergency room. Now we're trying to work them up and get them to the right provider or the right area to help them with their pain. But at one time, all of these people with abdominal pain would be referred to the emergency room. And again, consider that cost. We all know that just to walk through the doors of the emergency room, there's about a $500 additional charge then to a clinic visit. So that can be very astronomical when you look at great numbers of people. We, at the Samaritan or the Community Care Clinic, also provide emergency dental care. These people at one time would go to the emergency room with a toothache. We also provide some limited vision care, laboratory tests, pharmacy services, which includes a formulary, which means there's a list of medications that we can choose from. There's medications on that list to treat hypertension or diabetes or lung problems, asthma, for instance. But we must stay to that formulary of medications so that we can keep costs down. There are also screenings for blood pressures that are done, and with every visit, health information and education are done. We try to educate people where to get the services that they need without tapping on to additional costs. And we also provide community resource information. And I don't mean it's just Mary Kate and I providing it, but it's in the entire staff at Samaritan Community Care Clinic and our entire staff that try to help these people meet their needs. Other services, the medical assistance program through pharmaceutical companies is something that we try to get people enrolled in so that their medications can be paid for through the pharmaceutical companies. Currently, that program is assisting over 200 individuals and at times gets up to near 400. For instance, if someone needs a medication for their asthma that's not on the formulary and other medications don't work, we would contact the pharmaceutical directly, the company directly, and have them help this person get the medications they need. During the fiscal year 2009-2010, they provided $907,336 worth of medications in this program. That's almost $1 million. One full-time person works at just getting pharmaceutical for patients. We work very hard not to duplicate services provided by other organizations or government programs. In keeping with the mission, it's the goal to provide care to all those who have a need. What are we doing? Well, on April 1st, as Mary Kate said, 2010, the Agnesian Care Clinic was established to improve access for the underinsured. The nurse practitioners, and there currently are 3, and we've just hired another full-time person to serve these people. They will serve all the challenges that these patients have regarding access to care. They should be able to call and get in to see a provider within a timely fashion. We look at same day, if not for an immediate problem, if not the next day for problems that perhaps aren't as critical or as much of a priority. We've to date served over 2,000 patients of varying ages. We don't look at their cultural backgrounds, we don't look at their social backgrounds. They come to our clinic and we serve them as our patients. There's a little picture of Agnesian HealthCare.
So, why do you have so many more patients, and why are there so many more patients seeking care? A little thing called Badger Care, I'm sure you all have heard. Huge sweeping changes in 2009 to Badger Care. has improved access for patients and improved their ability to get Medicaid, which is our state-funded insurance. So our numbers went from 16 million, and it's estimated over the next 5 years to increase to 32 million. So we're hopeful to take our clinic model on the road and improve access to more patients so that they can have basic and advanced care as well. So this is the design that we've created in our clinic. It's over several layers, and we started with just opening the doors, and if you build it, they will come, and literally that's what happened. To date, as Louann mentioned, over 2,000 individuals. 2,000, that's a pretty large number of individuals who went without care, who are able to access care at this point in time in the last year, and it's not even been a year, we're about to celebrate our anniversary. In phase 1, we'll collect the data, see who is coming to the clinic, what their primary diagnoses are, and from there we'll build care sets or clinical guidelines, and I'm sure you all have heard of clinical guidelines, and we'll try to produce evidence-based nursing care for the individuals who are seeking care at our facility in a cost-effective way. Currently, the gross national product for healthcare in this country is 26%. In Japan, it's 6%, and their outcomes are in the top 5 and worldwide. So clearly, we're doing something wrong in this country, and we're hopeful that we can try and fix in our little niche of the world some of the healthcare issues that are going on. In phase 2, we hope to have more healthcare coordination, more case management with our registered nursing staff, as well as the staff from the Samaritan Clinic. And then in phase 3, we want to tackle some of the hospitalizations and the rehospitalizations of patients, as well as the inappropriate use of the emergency room. So we have lots of years of research ahead of us. So lots of opportunities. If any of you guys want to do some research with us, come on down. We'd love to have graduate assistants help us. They're all jumping out of their chairs now. Here's the clinic model. This is what we have designed, which is the first arm of our model. We started, and I'll let Louann talk to this since this is kind of where she started this clinic, with work-injury care.
We had done another study. Research is a very big part of healthcare, as we all know. We had looked at work injuries in the community, and people would go to various places for access, the emergency room and urgent care. They may go to their own primary care provider. But what we found out in our study is people would leave like sutures in for 2 months and not take them out because they didn't know where to go back and have them taken out, or they'd have back pain and they'd come in and be taken off work. So they thought that was like for the rest of their life. So they didn't have a follow-up appointment made because they didn't have a provider they could access. And what Agnesian did was develop a work injury clinic so people that are injured at work get redirected to that clinic. They're not costing the employer huge amounts to go through the emergency room, but they're seen by a nurse practitioner, and then the nurse practitioners understand work injury, and then they are returned at a timely fashion back to work, and the work comp laws get complicated. They understand these laws, and people are back to work the same day and with minimal medications and minimal days off of work. There's been a lot of research that say that people that are injured at work, if they get back to work, they heal faster, and it's true. You put them back with some modified duty. So that clinic is a part of ours, and it's been very successful.
So on the top, our whole goal is to improve the health of the community, as well as to improve the patient experience and the patient's healthcare outcomes. To do that, we feel we can do that in a cost-effective manner, as well as we can reduce emergency department, and I needed to add hospitalization. Any hospitalization that's unplanned, we consider a failure, so we want to try to reduce hospitalization. And there are some other arms that are down the road. This is down the road discussion.
We know it's not just us doing the work, but we partner with our patients. We include them right from the beginning in the plan of care and work with them to obtain their goals. We improve patient outcomes by doing this, and it boosts the quality care, and the communication is open, and it's a two-way party that's getting the communication together. It's achieved by focusing on evidence-based practice. We all know that things are changing in healthcare by the moment, and if we can get the latest and the most improved patient care and quality, we can get things done faster and better. It creates an integrated network that's accountable for both the outcome and also successful disease management.
Any questions so far?
I'm wondering what you think about how this, the Governor Walker thing is going to affect your clinic with all the cuts that he's going to make.
Yeah.
Can everybody hear her?
Use the mic.
Let's give her a microphone.
It's a very good question.
It's a fantastic question.
I'm just wondering with all the cuts that Governor Walker is making, how it's going to affect your clinic with all the cuts that he's making. There's a ton of them, so.
We realize that there are going to be some big changes. We anticipate we'll be busier than ever. We don't know all the details of what the governor has outlined yet. I do know tomorrow there is a panel of experts addressing those very issues. I anticipate larger numbers and more people seeking care.
Funding, though, isn't the additional funding to fund that?
Much,
There's no funding. How are you going to grow your program?
currently, the Samaritan Clinic is funded by monies from the community. They do the Samaritan House raffle each year, which gives the basis, and the Agnesian Foundation also helps fund it.
So they work separately but synergistically. So regardless of the funding source, we're always going to be there to serve our patients.
And one of our goals is, and that's through the work of the Samaritan Clinic staff, that they look to see if there are other programs out there available or if they qualify for medical assistance or Badger Care, and we help them to get on. That Badger Care process itself is a very tedious one, and a lot of people can't understand how to even get on the computer to access the program. They work very hard to get people the financial packets that are out there for them.
So the quick answer is we're not really sure. Any other questions for us?
Although it's been a working process, complementary and alternative medicines have had a vigorous debate on whether or not they're evidence-based enough to be considered in new form. What are your thoughts on clinical trials and alternative treatments?
Funny you should mention that. As long as it's evidence-based and it's in the patient's best interest, I personally am fine with whatever the patient wants to use as long as it's not going to be harmful. There's a terrific website sponsored by the National Institute of Health, so all of your tax-paying dollars at work, called nccam.gov. Write it down, it's a good one. nccam.gov, and it is a national complementary alternative medicine website. And they are doing randomized clinical trials on herbs as well as complementary alternative therapies to give some meat or to give some evidence and some actual data related to if it's working or not working. And I frequently will take my patients to that website when they're in clinic and they ask me what I think about chokeberry or what I think about cranberries. I say, well, let's see what the evidence tells us. And then I tell them what I think about it. But as long as it's evidence-based and it's working and it's not going to be harmful, I think it's a great idea. Louann, do you have anything else?
No, I agree. If it works, use it.
My one problem, just a small problem, is that some of my patients spend an extraordinarily large amount of money on complementary alternative medicine, and perhaps at the expense of other parts of their life. So I would strongly suggest a balance as opposed to putting all of your money in one spot.
What I find with many of our patients is the health promotion that we need to do, the education. They come in with bags of medications that they've had gathered over the years. Many of them are greater than 10 years old, and we need to help them sort what they have and get rid of what they can't take for one reason or another. And they also bring in their grandmas and their neighbors, and we talk about polypharmacy. It is a huge issue with people that don't have enough money to afford what they need. So they try to find it by other means, and we need to be there to educate them. But sometimes those things can be more harmful than good, which is most of the time. I want to thank our two gentlemen for coming today. One of our women didn't make it, and she's not out in the audience. I've been kind of scanning here. Cindy, if you're out there, please come down.
Not you, Cindy.
We're honored to have two of our patients here with us today, Timothy Bays and Todd Kleinhans. I would like them to tell their story, how they've accessed our clinic and what we've helped them to accomplish with their goals. So Timothy, if you don't mind, I'm going to hand you a microphone if you can just introduce yourself. Go first.
I got diagnosed with...
You guys hear him?
No.
Sorry. Start over.
My name is Timothy Bays. I got diagnosed with diabetes in November. I wasn't working at the time, still not working, looking for work. And a friend of mine told me to go to the Samaritan Clinic and they could help. Since that, I've got my medicine for my diabetes. I've been having a lot of health problems and didn't go regularly to see my doctors that I'm supposed to. If it wasn't for them, I don't know what kind of shape I would be in. My diabetes was high. When I went to the emergency room, it was at 494, and it scared me. I have hepatitis C that Samaritan Clinic is helping me with. Got a good doctor, and they're helping me get on medicine for that too. Day in a day, they go by that I don't think that something else is going to happen with me, with everything else. I just found in October of last year, I started having bad pains in my elbows. And find out today that it's a pinched nerve and it's weakening more and more. Like I said, I don't know what I would do if the Samaritan Clinic wasn't here for me. You know, a lot of my medicine I wasn't taking at the time and I couldn't afford it.
Thank you. Any questions, or we can come back to them as well?
My story is I got laid off at the end of this summer, and part of the reasons I got laid off is I had severe pains in my knees, and I didn't really know what it was. So eventually some friends of mine, he had gone to a doctor, an orthopedic specialist, and he talked to the orthopedic specialist, and the orthopedic specialist said that he would take some x-rays for me at cost so I could at least find out what was wrong with me. So I found out what I needed was a hip replacement. That was causing all the problems. But he said I needed to get some type of doctor going because I had to get other things checked out first before I could even think about surgery. So they suggested going to the county, and I found through the hospital the Samaritan program. So they got me in right away, which was a good thing, and that was probably the first week in December. And I had very high diabetes blood count. My blood pressure was way out of whack. Weight was too high. Just a lot of things wrong with me that I didn't even know. I probably was headed towards a stroke or a heart attack in about a month or two. They got me on the medication that I needed to get on. I ended up working with her. She gave me a lot of health information that I could use. I ended up dropping about 65 pounds so far. In fact, the good sign last time I went in, it said that I may be able to even get off my meds within the next 3 months. So they helped me get the things that I needed. But I still found out that I needed the hip surgery. And the Samaritan clinic, it was a little bit more of an expensive thing. So they helped me go through the program of going through Badger Care, where you can get your insurance for, right now the payment's $130 a month. And the girl who had the question of what's going to happen, I just got a letter yesterday. Badger Care is not going to take anybody else on this program, and my payment's going to go up to $200 a month. So that's some of the things they're starting to do, just so you know. So, but by getting this Badger Care, I got it in January. I was able to call the orthopedic surgeon that I went to. They took Badger Care, and I had my hip surgery in February. So that was 6 weeks ago. I'm in my 6th week. I just got off my crutches and everything. And one of the biggest problems I was having with being laid off is I was going to interviews and I could barely walk. I mean, when I walked into a place, I'm hunched over. And so I wasn't getting the jobs. I have the experience. I've been in the food business. I ran my own business. But people weren't looking at me because they didn't feel that I could do the job. And that was part of the other reason I got laid off from my other job, was because they wanted me to be doing more behind the bar and in the kitchen, and I could only do so much. So they helped me, Samaritan helped me get my blood pressure under control, that I could have the surgery, get my diabetes under control. They got me on the Badger program, which I go now. I go and see my doctor at least once a month. I get my blood test. And like I said, I did what she told me and followed the program, and it's working very well. And in a couple of weeks, I will probably be working full-time again. And my goal is to be working full-time, get a good job, and hopefully donate some money back to the Samaritan program. So, I mean, they helped me out a lot, and I wouldn't be where I am today if they wouldn't have gotten me there, and I couldn't have gotten a job without them. So I think it's a big part of a great program that the community needs. So.
Thank you. I want to tell the story of the gal that couldn't be here today. She came to our clinic, and she was kind of weepy. She's young. She said she felt so ashamed that she couldn't come in because she didn't have the money. She was trembling and shaking, and she looked terrible. She had been crying. I did a blood sugar on her, and I think it was well over 650. She had been off of her insulin for 5 days. And what she had done is gotten some Humalog, which is a quicker acting insulin, and taken a few doses from somebody that had given it to her that they no longer needed. When she showed it to me, it was dated about 2 years old, the insulin. She hadn't been taking her Lantus insulin, which is, for those that aren't diabetic, is a long-acting that you need to take every day. So her blood sugar had gotten very high. She had said she's drinking like incessantly. She said she would be drinking, not did she even go for a glass, she would get a pitcher and just drink the entire pitcher at one sitting. And of course, with drinking that much, she was urinating more. So she just had all of the signs. And when she came in, we needed to get her insulin, get her started back on it, and then see her for daily for about a week to get her insulin back controlled. But she was very grateful. We were very fortunate today that she was there, that we had from a pharmaceutical company some samples to get her the insulin and give her it right there in the clinic and watch her and get her back started on the road. And she has since been able to get back looking for part-time jobs and finding some jobs that aren't totally the income she had once had, but she is back in society functioning and feeling 100% better because she did get the care she needed when she needed it. And she, again, worried because she was a single woman who no one really checked on her, and if her blood sugar had gotten much higher, she could have potentially have died from it.
The last story we want to share with you is a patient that I didn't want to come today because she is undergoing chemotherapy right now, and I didn't want her to be in a room with a bunch of people. She came in to see us at the Samaritan Clinic in early November by herself, and she said she felt like she had something in her left chest wall. So automatically, we need to do a chest x-ray, and she was so concerned about the cost that I literally had to coerce her into taking it and telling her that I couldn't answer the questions if I didn't have the right data to answer the questions. So we did a chest x-ray. There's a very, very large mass, and taking up about the whole upper third of her lung, which is very large. Normally they're 2 to 3 millimeters, and this was several inches. So calling one of our specialists, our pulmonary specialists, he immediately saw her the next morning without hesitancy whatsoever, without any concern to her ability to pay for his services. He CT scanned her and confirmed that she did have very large mass that was a neoplasm or malignant. He also did a CT of her head, and it was confirmed that it was metastatic cancer to her brain. And this had progressed very, very fast. So a woman who never smoked, never drank, lived a very clean life, had a major, major diagnosis. So the pulmonologist referred her immediately back to us, and we set her up with the cancer center, and they immediately took her on and gave her excellent chemotherapy as well as radiation therapy. She came in to see me last week. She had a prognosis of about 3 months, and it's about 5 months in. And she came in to see me, and they said that her tumors are shrinking, and I think they might be scar tissue. So this is truly miraculous for her. So pretty amazing story. So the Samaritan Clinic does little things, does huge things, does really great things, and we're very fortunate to have the ability to do it. Thank you.
Any questions? As I look around the audience, I see some very instrumental people here to our clinic, and one person that really sticks to my mind is one of the nurses from the county health department. We've had our fair share of TB identified, and Ann Herman and her staff at the county have been just tremendous in helping these people get access to the care and medications they need.
I'd like to say though, if it wasn't for the ability to get our patients into someone and get them in right away, I mean, this is an issue that can impact our whole community. And usually the same day I call, we're able to get them in. And a comment I hear quite frequently from people that utilize their care is they were kind to me. They felt cared for. They didn't feel like they were begging for services, that the services were being provided with a gracious manner. And so I think we're truly blessed in our community to have this option. And I think that because I have someone that consistently deals with TB, we're developing a real good knowledge base about TB, so when they go in to see the provider, I don't have to do a lot of education because TB is not a high incident disease in the state. But when it occurs, you need to have good expertise to care for it. And I think by having a consistent place to refer people, we're developing a good expertise. So that's also a benefit for our community.
Thank you. We do have some very strict guidelines with the Samaritan Clinic. We do take any patient that comes, but there are things that we can't do. We don't prescribe narcotics. So it's not like people come to us seeking medications. The only ones that we can provide narcotics to are individuals that have had surgery. We also are the gatekeeper for specialists. For instance, if someone does come in with, for instance, an orthopedic need like Todd had, or like a neurological need like Timothy had, we first assess them to see if there's conservative treatment that would work, and then we refer them to a specialist as needed. We follow the formulary, and we also have like a formulary for medical imaging or x-ray as well. So we're looking at cost effectiveness. We're trying to do the best care for the patients that we can with what we have.
Marian and Mary Kate. Sorry. what are your biggest challenges in dealing with the patients that you work with and helping them gain access to resources?
There's challenges all the time, Julie. I know I had one this week that only spoke Vietnamese, and it was really a challenge. We were able to get an interpreter on a language line, but even then, some of the dialect from the area of Vietnam that she was from, she was older, it took us probably triple the time an English-speaking person would be. But then, go to find out when I did get talking to her, she had been in the emergency room a week ago, diagnosed with pneumonia, but never picked up her pills because she didn't understand the need to. And also finances were, even with the copay, they're not just given care, they're expected to pay a copay. She didn't even have that money for the copay. So it can be just multiple issues that are compounded. We can only do so much in the clinic, but what happens outside of there?
I think one of the issues I see is transportation. Patients have a huge barrier in getting to the clinic because often they don't have the transportation to get to clinic. So Agnesian will help voucher with taxis or with buses, but depending upon the patient's time schedule, that becomes very challenging. So I think transportation as well as communication for follow-up care, often patients don't have telephones, so it's hard to communicate. So we have to try and get as much as we possibly can done and schedule all of our future appointments at that same time.
And we have, literally have people that say they haven't eaten for 2 days because they didn't have food, and it's 5 o'clock on Friday and everybody's gone home. We've been very blessed. The Sisters of Agnesian have helped with money and getting people the food and services that they need on an immediate basis.
With the specialists, do you have them volunteering their time? Do you have certain ones that you send them to, or do you just get the bill from the hospital and pay that with your monies?
Yeah, we can direct that to our Terry maybe. Terry. I'm sorry.
Thank you. The community care program, the Agnesian Care Clinic, is very fortunate to have Agnesian HealthCare's foundation provide us funding so that a patient can go to a specialist with a voucher system. And our physicians are paid on production, but not paid. It doesn't go against their production, so I don't, for students, you'll learn that as you're in the healthcare world, and I'm not the expert to tell you about that, but through our voucher system. I'll give you an example. We have worked in this community for a couple decades with the dentists here in the community who have said, we want to help you. We want to help you see your emergency patients. And they have decided, as a community of dentists, that they will accept a donation from the Samaritan Clinics Foundation, actually St. Agnes Hospital Foundation, of $250 to have the work done that someone needs to have a tooth pulled, need to have their wisdom teeth taken out, need to have antibiotics for an infection, all that kind of thing. So as a community of Agnesian HealthCare, we have worked with the community to set up a guideline so that they can get the care that they are, and that a dentist can provide services. Well, that dentist is taking a big cut in pay, I'll say, for the work that's being done. All right, if I go to the dentist and I have a cleaning and he cleans my teeth, he puts a crown on and all that kind of thing, it's probably $1,800. And they are taking a voucher from us for $250 to do that kind of work. So as a community, they are doing a cost share for that. I also want to share one thing, if I may. Part of the Samaritan Clinic and community care is to look for outside resources. And we have been very fortunate in the state of Wisconsin with Governor Doyle to be able to expand the Badger Care program because it was only for families before that had minor children. And under his leadership, they expanded it so that our patients that didn't have any children could get Badger Care with that. And they got federal stimulus money to be able to do that from the government. And here in the state of Wisconsin, they put 80,000 people in 2009, starting in January of July of 2009 to October of 2009, 80,000 people on Badger Care. That was more than the state ever expected, and they had to put people on a waiting list. They actually closed that, and they put people on a waiting list. Then as a result of the waiting list, they decided that they would have a program that would cost $130 a month, which he's paying for, called Badger Care Basic. And that waiting list had 92,000 people on it here in the state of Wisconsin. Part of our clinic and our responsibility is to make sure that those that could get that service, we did that for. And for this fiscal year that started in January of 2010, or excuse me, July of 2010, we're not on a calendar year, we're on a fiscal year. Our office has saved Agnesian HealthCare $3.1 million that we were able to bill to Badger Care because of the work that we did for patients that walked into our door. And for the question about what's going to happen, we no longer can put anybody on a waiting list. We no longer can have anyone else pay $200 a month because they have closed those waiting lists. So what's going to happen in our clinics, we're going to get busier. And it's going to be more of a challenge for Agnesian HealthCare and for the foundation to be able to continue to assist the patients that we so dearly love. Thanks. Did I answer your question? One more.
I just want to say, I commend you guys for doing this. I work right now at a free clinic, and it's in Sheboygan. I live in Manitowoc, and I know we only have one in Manitowoc, which I think it would be wonderful to have that. There are a lot of people who cannot afford health care in my own little town. But to go to Sheboygan and just see some of the people come in, and they're struggling with even just being there because they don't want to be noted as a poor person. They don't want you to look at them funny and think, they just don't want a job, because that's not true. I get a lot of pleasure out of going there, even for a couple of hours. And so to see that you're sending something like this out to St. Fond du Lac, I think that's great. And I just want to commend you for that.
Thank you. There's no further questions. We just kind of want to remind you it takes a community, and thank you all for all you do. And Pat's waving our flag there.
Don't forget that. Fill out the evaluations and the amount of.
Thank you.